So cardiometabolic, getting the band together again. I was trying to find my slide deck from last year's annual cardiovascular update. I did give an update at that time of all the new therapies that are coming down the pipe, and a lot of these are really in the metabolic space. Um, you've probably heard me say this before, and if you haven't, I'll go ahead and say it here, is that most of the therapies that have come out recently in the as having clinical trials in the cardiovascular and also in the kidney renal space um, started out as anti-diabetic drugs, and really just they're truly cardiovascular renal drugs. They just happen to do a little bit on the glucose side of things. And so I think the best analogy, and the one that seems to strike home for my patients when I discuss this, is that if the dam cracks, let's say a dam at a reservoir cracks, and there's water where there shouldn't be below, you can fool yourself by cleaning up the water and not fixing the dam crack. And I think here, when we focus on glucose, that's kind of what's happening. You're focusing on a number as a surrogate and as a signal that something's wrong, and we're not necessarily fixing the issues at hand, and that's the metabolic dysfunction. So as we think about cardiometabolic dysfunction, I think that's the most appropriate. Diabetes falls inside there. It's has specific criteria for diagnosis, obviously, but I think perhaps it would be better served to really, I mean, we're all on a continuum, and remember that arbitrarily we've set A1Cs at 6.5% for diagnosis, fasting glucose greater than or equal to 126, and then random glucose that must be repeated with another glucose of greater than 200 are all kind of indicators of this diabetes. I think the real probably disease is type 1, and everything else is kind of a continuum of cardiometabolic disease. And maybe I'll convince you of that a little bit as we go through this. And Leslie, I said your name in vain earlier, so I'm glad that you're on to correct me at any time along this discussion that we'll have today. So here, again, just disclosures, I do have a research grant from Janssen for PAD, and then actually a consultant for a couple, ad hoc consultant now for a couple of different companies. So learning objectives, define cardiovascular kidney metabolic syndrome, or CKM, so much easier to say, and then review the interactions of these systems, of the different disease systems and the physiologic symptoms on one another. And ultimately, I think, I know we're a little cardiovascular centric, but ultimately that's what really kills your patients, my patients, the diabetic patients in this space. Cardiovascular events are really what ends up occurring for these individuals. So we'll kind of look at the CKM staging model. What does it mean? How does it kind of fall out with all of this? And then hopefully, gosh, this is great. We have such a good group of people here. We'll have a discussion of the interdisciplinary model of patient care management. I think this is where we really need to go to include screening for CKM, whether it's in endo, neph, primary care, cardiovascular, and who initiates these therapies, and where's the chronic management, and is it siloed, or can we better serve the patient and the community by kind of each taking some ownership and then really communicating with one another. So the definition of CKM here is simplified. It's what's in the new AHA presidential advisory. So it's a syndrome. I wouldn't necessarily call it a disease per se. I don't know that we have an ICD-10 code. American Medical Association owns that, but it's a health disorder that then connects all of these, right? Heart disease, kidney disease, diabetes, and obesity. I haven't called that out specifically until this point, but all of this leading to poor health outcomes. So then as a conceptual way to look at CKM and how they interact, this is kind of it. And I'll share my slides, but how does adiposity and obesity fit into all of this? Well, there's a lot of endocrinologic dysfunction that occurs as we have central adiposity. But all of that interacts. We see the new language of MASH and MASLD instead of NASH with an N, and NAFLD. Here to reflect that metabolic dysfunction, and not that it's not alcoholic, right? So we really want to point out that it's metabolic disease. And then all the separate kind of singular diseases that we tend to treat on an individual basis, but probably as part of a wider and larger metabolic syndrome or dysfunction that's going on. But all of these here kind of interact. You can see these arrows kind of go back and forth, and ultimately can lead to cardiovascular death, non-fatal MIs, heart attacks, and of course, kidney disease, liver disease, etc. So I think it's important to kind of see how they all interact, and that we shouldn't really be looking just at the one thing of our specialty. Yes, medicine's kind of designed that way, but I think we do our patients a disservice by only looking in our area of specialty, because they're starting to cross over. Here, the kind of the understanding, again, this set up through the HA advisory or presidential advisory statement of why we think CKM is a syndrome, and what the pieces of it that lead to us really thinking about this in a multidisciplinary fashion. So then here, I won't read all of these pieces, but it's part of that conceptual diagram of how they all interact with one another, why we should all be taking notice and feel really empowered to be able to treat, even, if you're seeing a patient in nephrology, yeah, please treat the cardiovascular risk, because ultimately they'll die first by a large percentage from a cardiovascular event before they even get to transplant or even dialysis. Most likely they'll have a cardiovascular event, and that's part of that renal disease process. And then also in the endocrinologic and metabolic space. So here's the stages of the cardiovascular kidney metabolic syndrome as proposed by HA. And I mean, this is how I think about it anyways, although I didn't stage it as such. So, going from left to right, you're essentially seeing, and we saw this with the atrial fibrillation guidelines that I discussed a couple of weeks ago, is really there's like the folks that if you have a heart, you have a body, you're alive, you're at risk of having something happen to you, right? And so the main point here is to point out that it's a lifespan kind of issue. So we really need to start with kids, children, healthier adults that have not moved on to the stage 1. And if you haven't been paying attention, boy, it's always eye-opening to go to the CDC's website and look at they have a GIF that shows from 1990s on to the present day. I mean, it's a heat map of obesity and how it's crossed over the United States. And we're going to be at a point where it's about 50% of the population meet obesity criteria within the next decade and a half. Although I have hope now with the GLP-1s. In any case, at this point, you're already starting that inflammatory process if you believe that conceptual diagram, which you should. But these folks are already at risk. They have dysfunctional adipose tissue, and that's already affecting both kidney and other, pancreas, etc., all other features. And then, boy, when you've unmasked a disease or one part of that disease process, this is the metabolic risk factors. They can happen in silo, or usually are found together. And then stage 3 is either subclinical cardiovascular disease. No, I'm sorry, I shouldn't say either. It is subclinical cardiovascular disease. Again, this is cardiovascular centric, recognizing and acknowledging ultimately, even when we're talking about, kidney disease or diabetes or hypertension, the end point that we worry about is the clinical syndrome. And so heart attack, heart failure, peripheral arterial disease, stroke, atrial fibrillation, and that includes those that you're treating for the kidney space, it's a smaller percentage that ultimately go on to dialysis or transplant, but that's also what we're trying to reduce the risk of and prevent. But generally speaking, they have one of these events in the cardiovascular space first. Okay, so it's always nice to kind of start the thought process here with a case. And so I wanted to start with this. A 75-year-old male who's presenting to clinic for follow-up. And really, he's kind of here to talk about his bad heart. It could be that he's following up in nephrology, actually. And even though he's like, oh, yeah, it is kidney, but man, I had, what about my heart? Cardiovascular space, obviously, it's a little bit more consistent with seeing cardiology. But he's had a stent, PCI, percutaneous coronary intervention, two stents that were placed about a year ago. He has type 2 diabetes. So then his A1C, we find out, is 7.5%. His BMI is 31, and he happens to have HFrEF. So we went through the heart failure guidelines a couple of weeks ago as well. And here his EF is 35%. So, from a social history, he's still drinking socially, but it's good to know that he did quit 10 years ago. So, rate of recidivism, he might come back to smoking. And that's something to kind of keep an eye out. No premature family history, or family history of premature events, etc. Non-contributory in this case. And then you look at his medications for someone that has type 2 diabetes, he's obese, has heart failure, reduced ejection fraction, coronary disease, and most likely has renal. We don't see anything on here that suggests renal up front, and so we probably need to get some labs, right? But his medications here, he's on dual antiplatelet therapy with aspirin 81, clopidogrel 75 milligrams. Does he still need that? Is it appropriate? He's on metoprolol succinate 75 milligrams, valsartan 80, spironolactone 25, empagliflozin 25, metformin 1,000, and then insulin. And I think hopefully after having several of these now presentations and discussions, you might say, we probably could do something different here, and there are a few more things that we ought to be doing. So, from a CKM standpoint, what is his staging? Where does he sit? And then what else should we or could we do? And so I want you to kind of think about that, and feel free to put it in the chat, because probably we'll cover it, and it'll be a primer for the the discussion and the answers that we'll kind of give each other over this case as we move forward. But the staging rationale here's stage 0. Again, they don't have any features of cardio-kidney metabolic syndrome or even those risk factors. So not overweight, no metabolic risk factors. Primarily, these are children and, sorry, I don't know why that's in there, but children and then young adults in the population. And, I think this is true primordial prevention, because I think of primary prevention as like high-risk individuals or people who are now hit my radar before they have an event. But primordial is even before that, is stopping or reducing the risk of developing a risk factor, such as hypertension or obesity, etc. And then the stage 1, this is the cohort or individuals that have excess and or dysfunctional adiposity. So, even before hypertension, hypertriglyceridemia, before developing any, pre-diabetes, metabolic syndrome, type 2, etc. But they have already started on the path of now setting in the potential dysfunction that can occur as they increase the adiposity. And this is generally speaking central adiposity. And you might start to see some impaired fasting glucose in these individuals. And in particular, I was listening to the original talk when they were presenting the advisory, and it struck me that these, they point out that women with gestational diabetes are often left just kind of hanging out there with no one addressing this issue, because they are at very high risk of going on to an event. And then I kind of like this. I mean, what do you see here? Just there's no wrong answers. Well, maybe there are wrong answers, but what do you see is happening to the person wearing a red shirt and then this person in the yellow shirt? Just it's as simple as that. There's no trick questions here.
You're drowning?
Yeah, yeah. I mean, that's what I would, that of course, yeah. There's a little bit of a top-down kind of thing. You're like, is Viet trying to trick us? No, no. I mean, this is, someone that's drowning, and what would you? I mean, so you're in this situation. What do you do? What? I mean, I don't swim very well, so I'm probably not going to jump out and try to save him. We'll both drown. What are some of the possible options here? What are you going to do?
Scream for help.
Okay, yeah, yeah. Like, hey, this guy's drowning. This guy's drowning, right? Person on the shore here is like, so anyone that knows how to, swim, please help out, or you go grab something to throw out to this person, right? Hopefully that's what we would do, or at least we would know there's kind of something to do for him, right? But what if this was the response? Hey, buddy, like swim. Don't you know you're drowning? Like move your arms and stuff. How helpful is that? I mean, is that the right thing to tell this drowning person? What do you think, Summer?
No. Like you're doing it all wrong, dude.
like stay afloat, man. You're going underwater, right?
Yeah.
Now let me just propose to you. That's kind of healthcare as it currently stands. So this is kind of the current medical landscape, and it's not just weight management, but it's other kind of things. We tell these folks you should eat less, you should exercise more. Calories in should be less than calories expended. Uh, they're drowning. They're experiencing this. And by the way, that person that's drowning is already trying to do something. Okay, they're trying to do something. It is not helpful. It is not helpful to point out something that's very obvious, and neither is it a helpful comment either, because most likely they've heard this and they've tried this and they've done that, and it's not working. The circumstances are such physiologically that that drowning victim, whatever disease state it is, they've probably been trying that. And at 40, if that's the first time you've heard that, probably not a good thing, but it's probably not the first time they've heard that. Okay. So I just wanted to point this out because I just came back from a Heart House roundtable at the American College of Cardiology where we talked about weight management, cardiovascular disease, and unfortunately, I was in a room of 40 experts in this space who all do weight management in some way, shape, or form, and some are they are obesity management experts. This is what their patients tell them all the time that they hear from us, from all of us. I mean, just collectively, the healthcare system and medical people. Just please, just remember that it is not helpful to point out the obvious. We should do things and help them get there. Teach them how to swim and give them support. And in this case, throwing out a line might be similar to, hey, I know these, bariatric surgeons that might help. I know of GLP-1s and those kind of things. So I'm just flipping the script a little bit so that we recognize there are some things that we probably do and say that reflect more of our bias of like, yeah, of course, I've been learning this and I know this, I've been practicing 15 years. And then you expect, that maybe the community member doesn't know what you know, but you tell them the most obvious thing. So I just wanted to, I'm sorry, I'll get off my soapbox, but I think it's important that we recognize this. So then coming back into this, as we talk about hypertension, dyslipidemia, chronic kidney disease, type 2 diabetes, this is now, they have the presence of metabolic risk factors. They've moved on from the stage 1 to stage 2, or perhaps they're kind of bridging the gap there, but they've manifested these singular metabolic signs, right? And so this is stage 2 now. You haven't developed the events of interest, and you have no signs of like subclinical cardiovascular disease, but this is where it starts. And we might be now seeing someone that's got 3 fingers up out of the water, and they're like, okay, they're pushing up just a little bit, but they're in trouble. So then here, perhaps this is the 3 signs up above the water, where it's subclinical cardiovascular disease. They're more often down than they're up above the water line. And so coronary calcium. I don't know how many of you have ordered coronary calcium, or you manage coronary calcium, or have a discussion with coronary calcium, over coronary calcium with your patients. But it's a fantastic way to assess patients for not risk factor, but actual development of disease. So I look at it as assessment of disease burden. It is not a risk factor. It is the actual development of atherosclerosis. The question is, when is that going to rupture, or will it rupture? Not are they developing atherosclerosis? They have it. So these are the kind of things that I would say in stage 3, when you identify these, we're probably now seeing someone that, again, is more often below the waterline than above the waterline. So I think as we consider therapies, and we consider educating patients about therapies that we want to have them consider taking, because ultimately they're the ones taking it, we should understand that rationale, and we should be able to explain it in that context. Is that we're not pretending you have cardiovascular disease. You do have it, and you've manifested it. The question is will you have an event, and when will that be? Can we stave it off? Can we push that timeline 10, 15 years further down the road, or perhaps not at all, that you won't have it at all. So here then is the stage 4. This is the last bit, and they have now had an event. And then in the kidney space, this is the stage 4A, but without kidney failure, or stage 4B. Now they're having present kidney failure. And then what do we do with all this? I think it's so amazing to me that we live in a time where there are like 3 therapies that I can think of off the top of my head in terms of classes that bridge the gap across heart failure, kidney, and cardiovascular. And these are now completed phase 3 trials, and not just one, but several phase 3 trials across 3 classes of therapies. And unfortunately, this is someone that's already gone under and probably swallowed some water. And when you bring them up, if you recover them out of the water, they may have some residual problems. So this is the victim that is in the process of drowning, and has, again, stayed more often down below the water than above the water. So we're hopefully the analogy helps to say, well, maybe we should be pointing well before they get into the water. Let's teach them how to swim. This, yes, of course, people will jump in high tide and rough waters, etc. You can't fix stupid. I'm talking about me, but you can at least give them some tools ahead of time. And I think that's where stage 0 is helping people to learn how to swim well. And then after that, can't, like I said, can't fix stupid. But once we're in the space of seeing a patient, regardless of where the staging is, they happen to follow into your clinic, and they're scheduled. I think most of us are in the adult space. I don't see any peds, and we see as young as 18 in my clinic. Here, the proposed screening schedule from the American Heart Association is really 21 and older. I don't know why they made that distinction. I'll have to go back and take a peek at the paper, but for whatever reason, they chose 21. So whether they're being seen in nephrology, endo, cardiovascular, primary care, then I really do believe these are the things that we should be doing. It was kind of humbling, actually, and a little embarrassing. About 7 years ago, I bought a whole bunch of tape measures for the clinic so that we could do this. And I measured the waist circumference in clinic 5 times. So I meant well. And I just never got back to it. And I don't even know where our tape measures went, because then, like several years later, we moved here to building 1 and we don't have a single tape measure in any of our clinics. But the reason why I bring this up is that it's such a simple measurement. It is such a simple measurement, and it's much more prognostic than BMI. And it's closer to looking at body composition and describes central adiposity so much better than BMI. And I don't say my BMI to, it's for context, but I am a 30 BMI. And for those of Asian descent, 27 is obese. In white populations and other populations, it's 30 is obese. And so you're looking at an obese individual by BMI criteria. And I certainly feel that way, but I think a waist circumference is so much more helpful as to what's my abdominal circumference, what is my hip to waist ratio, and that really gets better at where the metabolic dysfunction is. So I plan to, and I've got Merritt and Leslie both on here, but I plan to develop an education piece and leave a tape measure for the patient to, if they feel comfortable and if they are curious, they can measure themselves, and I will try to do better at measuring them. But I'm going to leave it out with an education piece of why it's important to know your waist circumference and your hip to waist ratio, and allow them to do that. And it'll have some tips as to why that's important to know and then what to do about it. So anyway, that's some a little bit off topic as to what I'm planning to do. But I am totally embarrassed because at this roundtable, I can't tell you how many obesity specialists raise your hand if you're a cardiologist or work in the cardiology space. And a bunch of us raised our hands and like, when was the last time? No, at first the question was, have you ever done a waist circumference measurement? And my hand went up, but it was like, embarrassed because I knew there was going to be a follow-up question. And it was like, when was the last time? And I couldn't remember when, but I knew at least on one hand, I could count how many I've done. But anyways, please think about it. So blood pressure, A1C, lipid, we know these, and we've talked about, when to do that. We look at the clinic blood pressure all the time, but there are now great papers out there that tell us really the home measurements where it's at. That's more consistent, and it's something that patients should be doing and engaging in. I'll just say that, it makes no sense for me to manage heart failure exacerbations based on a clinic measurement 3 months ago. I asked the patient to follow that, and then we do diuretics. So why would I do blood pressure management off of a clinic measurement 3 months ago and not based on what they're measuring at home? So just putting that out there. Microalbumin creatinine, that is, I'm preaching this because it is something that I've been doing a whole lot more. All of my diabetics I check. I shouldn't say my diabetics, but patients with diabetes that I share with others, I always check if there was one done in the last year, and if not, I measure that. And then the MASLD, Merritt might have some comments on this. I put it out in our big group me chat for the APPs in general within Intermountain that are on the group chat. And, I kind of discussed this, like, what do we do? How do we do this? And can I order fiber scans, etc.? And it turns out it's a little bit more difficult. It's not, even though it's in the guidelines, it's not as easy as we think to do those kind of things. And what do we do? Well, hopefully we'll kind of cover some of that today. But we should be screening for metabolic liver disease. And whether that's, steatohepatitis, whether that's actual fibrosis, et cetera, is something we should think about. And the coronary calcium is very easy. If you've not ordered one here, and in particular, if you want to order one, there is a cash pay option. Please choose that. You have to order it as cash pay, but it's $89 for the patient. Otherwise, when I did this the other way, they were left with a $200-300, sometimes $500 to $1,000 bill. when you try to run it through insurance and it doesn't go through, just do it the $89. And it's a great way to get some information on your patient management. Okay, so I thought this was a great conversation by the primary authors, principal authors of the American Heart Association's Presidential Advisory. And they kind of split this off into value-based in terms of interdisciplinary models, value-based versus volume-based. And here we're at Intermountain. We've already said we are going to go to a 50% at least model of value-based care. And what that means is we're going to take a lump sum and do all the things that are important to keep them from coming in for procedures that they are not necessary. Obviously, we want to be able to do procedures when they're necessary, but all of that care will be provided for prevention versus fee for service, where we're like, yeah, go ahead, eat some more of this and that, have an amputation, we'll be paid for that. Get a stent, great, dialysis, wonderful. That's money coming in. So value-based care here is this idea that we give all the care to reduce events, to try to protect them from an event, but in an interdisciplinary team model. And that's actually what I've been trying to do for the last 2.5 years, is bring a cardiorenal metabolic, but cardio-kidney metabolic clinic that has members of these teams. And I thought it should be run by internal medicine or family practice, but it would have some specialists from nephrology, from us in the cardiovascular space, and endocrinology. But then it would have a designated, nurse and coordinator, et cetera, and even have pharmacy. And it exists out there, by the way. We've been in discussions, et cetera. I like that model quite a bit. Otherwise, it's this volume-based care where we don't blast nephrology with everyone and anyone from CKD, 2 on down to 4, but really because of access, maybe primary care, cardiology, and whoever's managing that patient, pre severe and end stage, maybe we can be helping that out, and then target referrals so that you're seeing the more complex patients and the ones that probably went too far down that road, and you're trying to recover them, and not being distracted by all the patients that we can be managing. Same with endo and cardiology is, can nephrology and endo be treating lipids and hypertension? Yeah, that's what you do. And to be honest, hypertension was a nephrology thing that cardiovascular took over. Endocrinology, lipids was an endo thing that cardiovascular took over. So, we're the baddies here, but targeted referrals to specialists. So I like that. Here in the stages 1 through 3, as you remember, 0 is kind of, let's teach them how to swim well, practice, etc. Keep swimming. And then 1 through 3 is any number of uh-ohs where the patient looks like they are starting to get under the water more often than they're staying above the water. And then, what do we do for them? What's the care? I really like this. It really gives a nice detailed way of thinking of these stages and what the therapies might look like. In stage 2, again, these are, the singular one-off, or maybe they have multiple of these risk factors in the metabolic space. And what do we do about it? How do we approach it? What's, where are we going off, and what do we add at that time? And then, of course, the subclinical space, how do we ramp up as they're moving towards drowning, and more often under the water than they are above the water. And then stage 4 here, where, they've breathed in some water. They are definitely just a couple fingers up above the water, and then we've pulled them up, and we're trying to recover them and keep them from going back under. So, what do we need to do? Where do we target therapies? And now within these spaces, we are intensifying therapies. I don't like the term aggressive. I'm not becoming more aggressive with you. It just feels so violent. But we're intensifying therapy. We're becoming more intentional about, stepwise progressing those therapies appropriate to the needs of the patient. So here, our nephrology folks, you're very well versed in the KDI Go map here. Here's the GFR side, and here's the albuminuria side. And it always just strikes me that folks that have a GFR greater than or equal to 190, or excuse me, not 190, but 90, can still have moderate, renal insufficiency, and even severe, or I guess mild to moderate insufficiency, as we seek to do a UACR, get an albumin creatinine ratio, or urine albumin creatinine ratio. And then, of course, the rest of us just targeted so much on GFR, but recognizing how quickly patients can fall into trouble. And I like this monitor and refer, treat, etc. Even in that 45 to 59 range, where honestly, I think if you talk to a lot of providers, they wouldn't this wouldn't raise any red flags for them. Yeah, okay, yeah. It's not below 30, is kind of the, and I don't mean to be cavalier, and I'm not denigrating folks, other than we're just not aware of how quickly our patients start to drown, and how quickly they can tip over into needing dialysis, or transplant, or just now when they drop down permanently, you're limited in your therapies that you can supply because they're renally excreted or renally metabolized, and that's problematic, right? So not just that they need dialysis or transplant, but rather now you're limiting the therapies that can be deployed because they cannot metabolize or excrete those appropriately. So I like this, green, yellow, red, orange, red, and it falls into this space here where for dummies like myself, I just need a visual. And if the CKD, KDIGO map falls in green, great, okay, they're like on land or just up to their knees in water. But then, things are going south, and I probably need to refer to nephrology at this point. Um, I, I don't want to tell you these, like read these one by one. I think we kind of understand that there are therapies that are out there and what we can give, and what we can provide our patients in terms of tip sheets. So just pointing out that these are there, and someone as dumb as me can take them and supply or apply conversation and therapies to these individuals in this space. So, I would like our nephrology partners to kind of chime in here. When do you want to see patients? Of course, I put the very high risk, and then there's the KDIGO map, refer, monitor, etc. And then in the KDIGO guidelines, this is from 2020. This is when it triggers a nephrology referral. So when would you want to see someone from us? And how should we wrap them up, or gift wrap them, tie a bow, and say, please help out?
His mother said yes to that day.
Does any of that look wrong, Dina?
Hi, sorry, I was having issues with my mic. Something that we kind of created was that kidney risk score, and we say like 5/5 as like a general rule on getting a nephrology referral. So if their 5-year risk of needing kidney replacement therapy is greater than 5%, if I'm saying that right, that prompts a nephrology referral, or 20/2. So if their 2-year risk score is greater than 20%. I'm sorry, I can't hear you. My computer's been a little glitchy, so my audio is a little in and out.
No, you're okay. I was having quite a bit of sound, ambient sound right next to me. So no, that's great. Can you? How do you calculate that, and what are you? Are you documenting that? How does that occur? And can we do that? Do you have a hot text or a dot phrase that you use?
We don't have a dot phrase, but we have implemented it within iCentra and it's ordered as a kidney risk score, and it's ordered with a chemistry panel. So it calculates your UACR along with your like estimated GFR to give you a risk score, but I'm going to share this website where you can kind of input information that you have on your patient to calculate a kidney risk score.
Yes, thank you.
And
So
this is off
5%
like the
or
Tangri
higher.
risk equation. Yeah.
Okay.
5/5 or 20/2. Because when you input the information into this calculator, then it'll give you a 5-year risk score and then a 2-year risk score.
Okay. Well, perfect. Thank you.
Mm-hmm.
That's very helpful. Okay. And I might have to poke at you after I use that a few times.
Yeah, of course.
Thank you.
Mm-hmm.
So here, moving forward then, just, and I won't go through all of these. Just want to let you know it's in the slide deck. These are just great ways of thinking about our patients. Again, this is, specific to diabetes with chronic kidney disease. And then, of course, the foundational part of all of this is lifestyle and self-management. Sorry, somehow the E fell off of there. But, I've been accused of being a shill for industry. And I would say it's only because of my excitement that we have so many wonderful therapies now that, honestly, when someone is drowning, to tell them, swim more, don't go under the water so much. Well, sometimes they kind of need the rope thrown out to them, and they need that whatever we call that, the donut that we throw out to our patients, that lifeline. And perhaps they don't have to be on it for the rest of their lives, but some type of dysfunction is occurring. So we need to think about that. Here, I think, and sorry that all fell off, but I just wanted to show that intersection of how CKD and heart failure come together, and all the different studies here. And this is the SGLT2 studies, right? That we now have showing, that's one of the classes of drugs that we really need to be thinking about and considering first line in all of our patients, and only not providing or cautioning in certain circumstances. But by and large, most of our patients, the majority of our patients, should be able to start SGLT1, 2, or SGLT2 type therapy, and then just monitoring, of course. Let's see here. There we go. And then just residual risk. So just again, coming back to how it's a risk multiplier when you start to combine metabolic disease and chronic kidney disease. These folks are the worst off here, where they now have the intersection of all three things that are happening. This is the stage 4 folks, right? But we just are not doing a great job from the cardiovascular space, thinking back to, do they have metabolic disease in the forms of diabetes and liver, etc.? Do they have kidney disease? And we're not really thinking about that soon enough in our patients. And maybe you find that in your own specialties as, I'm not thinking about cardiovascular disease so much, but I'm just, keeping this kidney from going downhill. But why? And should we both be thinking about diabetes and initiating therapies? Again, thinking of the analogy of the dam, we're no longer just kind of cleaning the water underneath. We are trying to fix the foundation. The fundamental piece here is that dam has something wrong with it, and we're repairing it. Coming back to the 2023 ADA standards of care, you've seen this before, and they address this entire cardio-kidney metabolic space where, this is diabetes. This now is the renal side. Here is the cardiovascular side. And you'll find that in all of these areas, SGLT2s cross all of them, and then GLP-1s are crossing all of these as well. We are seeing benefit in the heart failure space as well. Here we're doing the Summit trial, which is looking at tirzepatide, which is a dual incretin. So it's not just GLP-1, but GIP as well, glucose, excuse me, insulin peptide. So GIP. Well, Leslie can correct me on that one, but we're seeing that all of these cross over in this space. I just wanted to remind you for GLP-1RA, there's only 3 that have had randomized clinical trials in the cardiovascular space, meaning AMI, heart attack, stroke, peripheral arterial disease. That's liraglutide, dulaglutide, and semaglutide. So sorry, it looks like exenatide here, but these 3 here have randomized clinical trials. And you'll notice that I don't include Rybelsus, the oral version. It's only the injectable versions that have shown cardiovascular disease reduction and have the FDA indication for that. And then, well, these are diabetic medications. So what about people with heart disease, like they've had a heart attack, their BMI is at least 27, so me included in terms of being Asian, but of course BMI 30, and then no diabetes. Well, that's the SELECT trial, and that completed last year, was reported out. Guess what Wegovy has? It now has an indication not just for weight management, but for cardiovascular disease risk reduction. That is a new FDA indication, and I have been starting to try getting folks on this therapy, and I'm trying to avoid anywhere on the ICD-10. I don't include weight management, only cardiovascular, because they're denying it whenever they see weight management on there. So in this case, I feel very comfortable in saying it's for cardiovascular disease reduction. The data shows us that, and it has the FDA indication. So that's the SELECT trial. Here are the cardiovascular outcome trials for renal outcomes in the GLP-1RA space. And you'll notice that in meta-analyses that it does have benefit for a relative risk reduction of nearly 18%. And so I think, do GLP-1s work there? So here's, of course, the SGLT2s. We've seen this before, I think, but here are the GLP-1s, and that leads us to the FLOW trial. So the FLOW trial just was reported out at the European Renal atherosclerosis or artery, I don't know what it was, ERS is what they call it, but it was reported out in Europe. The FLOW trial was stopped early, and that tells you, it already tells you they met their primary outcomes. But in first major kidney disease event, there was a risk reduction. In first cardiovascular, this is death. There's very few therapies that you can show directly with cardiovascular mortality. Here's first major cardiovascular event. All of these, this is 18%. This is nearly 30%, and 24% here. So this is why anytime and anywhere possible, I think of GLP-1s and SGLT2s, and in particular in combination, because the data, time and again, we're fixing the dam. We are no longer just mopping up the water underneath. There are fundamental physiologic things that we are repairing when we use SGLT2s and GLP-1s. And so I am grateful for the FLOW trial, the SELECT trial. Of course, both of these were semaglutide. And we'll start seeing some data come out of tirzepatide, which is the dual incretin, and then we have retatrutide, which is a triple incretin therapy. So anyways, let's come back to this 75-year-old gentleman who presents the clinic. As you'll recall, he ostensibly he came because of his bad heart. He's had a stent a year ago, and he has type 2 diabetes. It's not fully quote unquote well controlled, but that's like, I don't know. I hate that term anyways. I think that they still have metabolic dysfunction regardless. We spend a lot of time thinking about metabolic syndrome and how is 6.5 any better than 7.5 in the space, because we were generally worried about hypoglycemia, which is not what we're seeing. And really, hypoglycemia is a focus on glucose management rather than metabolic dysfunction. So here, obesity 31, HFrEF 35, so what is our thoughts? Staging wise, we kind of went through this. They're already into I drank water and I'm drowning. So they're stage 4. But what else could we do? Should we do? Type it in if you want. But I'd like your thoughts now that we've kind of run through this. Is there anything different you do? I'm going to call Merritt and Leslie out in terms of the cardiovascular side. Would you do anything different with the medications?
So this is Merritt. Depending on his vitals and his lab results and all that stuff, I'd probably consider stopping one of his antiplatelets. Seeing if we can stop metoprolol. See if we can get him on a GLP-1 and get him off the insulin.
Okay. Yeah. Leslie, thoughts?
You were asking just about cardiovascular?
Well,
Or
yeah,
about all therapy?
yeah, because we're kind of cardiometabolic, right? So
Right.
yeah, speak specific to cardiology, what was traditional cardiology, but you tell me. Yeah.
Well, yeah, I mean, Ozempic's been approved for cardiovascular prevention, so it is a cardiology drug. So I think that would be a good addition. A1C is not under control. And yeah, so I would start Ozempic in this patient.
Okay.
Depending
Great.
on, I have a lot of questions I'd have to ask first.
Of course, yes, yeah, and so we're, this is kind of the hypothetical. We haven't generally gotten much else in the space, but just off the top, right?
Right.
And I'll just add here. I know, and probably you forgot that the
exactly.
HFrEF is 35. So I would keep them on the
I did.
metoprolol. Yeah. I kind of thought that. No, it's okay, because this is a complex, right? These are complex patients, and they come with all this stuff. So you have to okay, not this, but that, but oh yeah, they're on this because of this, and it gets very complex. And I think if we can de-escalate some of these, I would move to a single antiplatelet if possible. And again, it would depend on how they fared here, but in general, the data is with us for going single antiplatelet. And my druthers is a P2Y12, so whether it's clopidogrel, prasugrel, whatever, I would prefer a single agent to be a P2Y12 inhibitor. Again, not knowing the blood pressure, I'm not sure I would change these, other than I would move to Entresto or sacubitril valsartan in the EF of 35%. And the reason being is we've done this trial. That's the paradigm trial of sacubitril valsartan against enalapril. And if we have the capability, then I would go ahead and move them to that. So it's not adding, but rather switching this out. The thing that I would think about, again, I like GLP-1s in this space for all the features that we've talked about, and most likely, and Leslie, has comments on here too. Is with the insulin, you're gonna try to offset that a little bit when you add that GLP-1, and be careful not to throw them into a spiral there. But now I want to hear from my kidney partners here, my nephrology. Oh, so Leslie, did you have something?
Well, just Aaron had an excellent comment, so in the chat.
Thank you, Aaron. So you had 3 cardiology folks, and we again, complex, right? Complex here.
You left off his lipids. What do you expect?
I did. So this is an individual, by the way. Thank you, Aaron. So is this person stable cardiovascular disease, or are they very high risk?
I think high risk.
Okay, good. I'll remind you that very high risk is either one event, or excuse me, very high risk is 2 cardiovascular events. That could be stroke, PAD, or it's 1 cardiovascular event with 2 or more risk factors: hypertension, diabetes, greater than 65 years of age, former smoker, obesity, heart failure. This is very high risk. And so what's the LDL cholesterol threshold or goal? Is it less than 70, less than 100? Garrett?
Less than 55 in his case.
Yeah. Yep.
I mean,
less than 55. Do you have a second follow-up comment on that?
no, not particularly.
Okay.
So I guess depending on how far you could get him on a statin, or maybe he just forgot as part of his drug list. But if you need to augment that with something like ezetimibe or a PCSK9 inhibitor if needed to push it down that low.
Perfect. And we don't have a baseline, right? We don't have a baseline. I didn't give a baseline. And yeah, it just as often as not, they've forgotten to tell us about their statin that they have been taking, etc. And so in the least, you should be considering very high or a high intensity statin therapy for 50% reduction off the top. And I would find it would be easy rather than adding a pill. Look at his list already. We're gonna, add more therapy probably. I would consider PCSK9 because of the magnitude of lipid reduction. But if cost is an issue, ezetimibe is a great therapy to add to what he's doing. And in fact, if you were thinking PCSK9, I would consider inclisiran. So he was getting his injections once every 6 months rather than once every 2 weeks. So other thoughts here, Aaron? Thank you for reminding us about the statin. And yes, of course, transition to ARNI rather than ARB. I love it. Aaron, great question again, and it's one of the things I wanted to ask our NEF folks, because I am I know Leslie, you're not as convinced as I am. I happen to be on non-steroidal MRAs, but finerenone, and where does it sit in all of this when we talk about this spironolactone here? MRA versus non-steroidal MRA, and in this case we have the indication of HFrEF, but does finerenone fall in this space as well? Is it as good in terms of being one of the 4 pillars of guideline-directed medical therapy? And I don't know. Actually, I kind of suspect, and I may not have seen it. I'll look that up in terms of the heart failure guidelines. But I understood someone to say that it was included. No, it wasn't included. Never mind. I was thinking of the SGL1/2 sotagliflozin for the SGLT2 pillar. But yeah, I mean we saw that in Fidelio and Figaro, and then in their masked Fidelity, which they took both cohorts and mashed them together. And what you see is it does reduce, or as there's a signal for heart failure reduction as well as cardiovascular event reduction. And so I think so. I think that you should be able to consider finerenone in the space to cover the chronic kidney disease, to cover the metabolic portion of this and the heart failure portion. So I'll see if I can dig up ongoing phase 3 trials for that, so that we can put it in the chat here. Any other questions to that extent, or our nephrology partners, have you run into that, or I don't know if you do any hand wringing over that? No, I don't know. Dina, Summer, any thoughts in that space?
Hey, I had to step away for a sec. So I
Oh,
need to get
okay.
caught up with the topic right now.
Yeah, so the question for me was really, Aaron placed in here a discussion about HFrEF and then an MRA, so spironolactone, even a eplerenone, versus finerenone, a non-steroidal MRA. Do you all look at that and think about that at all in your patients that you're seeing for your clinic, but happen to have HFrEF?
Yeah. Well, I can speak more for just CKD patients with positive UACRs where we're pushing for the eplerenone over the spironolactone. But I'm not sure really about CKD and HFrEF if we're choosing one over the other, but I also kind of get advised to just try whichever one can get covered at a decent cost for the patient. Because spironolactone is known to be a lot more affordable than that is kind of our what we end up resorting to. But I don't know. I see Summer and Megan are also on, if they can chime in about this, if you guys have experience.
Yeah, I've tried to use finerenone, but I've had a really hard time getting it covered. I've only successfully got one patient on it so far. So I usually stick with the spironolactone or eplerenone, just based on that.
Is that about the same for you, Summer?
Yeah, I've not been able to get anyone on finerenone, but I listen to Dr. Krause is often kind of said, that it's superior, but it's one that's been difficult for us to get covered. So
Yeah. Interestingly enough, I have been able to get a few patients on finerenone. I just don't think about it often enough, I think, but I'm so focused on spironolactone and eplerenone, although I haven't done eplerenone that often anymore. But my trick is I usually will go to pharmacy questions in Cerner, iCentra, and then ask them to do the entire review of prior auths, et cetera, if it's on formulary for the patient or not. And that really, that step is so helpful because I find that it is approved but needs a prior auth, and then at least I know which patients to go ahead and do that. And then I've had to do letters of appeal, and it does get through. But it is a process, and you probably should designate someone in your clinic to do those prior authorizations. We've inundated our 2 or 3 MAs and schedulers and trained them up to start doing prior authorizations across multiple different therapies, and so they've had some luck with finerenone or Kerendia.
Do you associate it with heart failure, or if they don't have CKD, if they just have heart failure, then maybe that's what's pushing it through quicker than just a patient who doesn't have heart failure and CKD?
No, I don't, because it doesn't have the indication for heart failure. But for my diabetic patient or patients with diabetes, almost all of them have a GFR that's less than 60. And so that's how I do it. Yeah, I just follow the indication strictly, and
Okay.
That's been successful. Yeah, you just document it, make sure it's documented in your note, and then I just come right at them with the diagnosis. And when they push back, then I give them the references for Figaro, Fidelio, and then Fidelity. And yeah. So whoever is the uneducated person saying no, then they're like, oh crap, he gave at us with data. So goes through.